gallbladder.
Take that stuff out.
All right. Anybody heard our lovely little acronym for gallbladder disease? Who's likely to get it? Risk factors. Risk factors for gallbladder disease. Go for it, Zach.
4 F's.
4 F's. Yep.
Female, 40, fair-skinned, and fertile.
Fertile.
Yeah.
We're also going to add a fifth one to there. We're going to say fluffy.
Wait, me.
So, huh? So female, fair skin, fertile, fluffy. What was your other one, Zach? I missed one.
Over 40.
40. Thank you. 40. 4 F's. There are several patients that will have gallbladder issues. We're going to hit some. So, it is most often caused by our gallstones. So, our good friend, what electrolyte loves to make stones? Calcium. So, some of our hypocalcemia patients, it's not bloodstream, but hypocalcemia, right? So, you have to think opposite with calcium. He's the one that doesn't act right. Hypocalcemia, because it's not in the blood, it's in all these other places getting stones, but your hypercalcemia can have stones as well. Calcium. It's going to obstruct the bile flow, so the sac enlarges from the increased bile production or storage, and gets, anything that sits gets infected and causes inflammation. Some of your most often patients here, we talked about dietary wise, they're going to be also in that, so fatty, fried, and spicy food lovers, that can agitate our gallbladder. Because if we need more bile's put over in there, things like that. The other group of patients that routinely has gallbladder disease is severe weight loss, like quick. So people who get immediate, so we'll pick on Anna, she pointed herself, so I don't feel bad. So like bariatric surgeries that have those, they have sudden, just huge amount of weight loss, their gallbladder can't compensate, it gets irritated and has cholecystitis. All of our Ozempic people are winding up with pancreatitis and cholecystitis because of that sudden large amount weight loss. So that's your most common too. So dietary, fatty fried, eat lots of high fats, are prone for this. Your hypercalcemic patients, because lots of calcium makes stones, or severe weight loss. I'm talking like hundreds of pounds quick. So the hallmark here is going to be right upper quadrant pain, and it is tender, extra tender to palpation. Do not touch it. So in the same token that we had McBurney's, which was where?
Lower.
There's McBurney's. So Murphy sign, same thing, midline in the right upper quadrant. So we got Murphy's up there. So the difference is, McBurney is when I lift up that I elicit pain. Murphy's push down. So I don't know how you want to differentiate. Sam's usually got a cute little something, she can come up with something. So McBurney's not when I push down, but
So,
I don't know.
I just said RA, room air, so RA, right for, that's how I remember it.
But Murphy's is gonna be when I press on that right upper quadrant. Murphy sign.
Murphy if you mush it.
So usually you're gonna have that right upper quadrant pain, positive Murphy sign. So far, I don't really, there's another disease coming up that will kind of have those. Murphy sign is the only difference between the two. But pain management, we're gonna make NPO, because what's gotta happen, it's just like your appendix, what's gotta happen?
Surgery.
Gotta go, so lap colectomy or a laparotomy, depending on the situation. IV fluids, since they're NPO. We are worried about peritonitis yet again, because it's a GI surgery, but we also can cause pancreatitis. So you remember my little metabolism triangle? When gallbladder's out, liver and pancreas have to pull the extra weight. True story, I don't remember whose clinical group this was, but we had it in clinical recently. We had a patient who had cholecystitis, and she could not have her lap chole until she improved her, pancreatitis. Hey, you looking, was that yours by chance,
I
Haley?
think so.
Or
I'm
Haley?
trying to figure out where you.
I can't remember the room, but anyway, she had, cholecystitis was her main problem, but her amylase and lipase were elevated because her pancreas was having to pick up for the lac, and so they did not want to, take the gallbladder out because they knew that those levels would increase even more, and we didn't want to send her into pancreatitis. So we had to wait on that to resolve until that she could have her surgery. So pancreatitis, very common occurrence with gallbladder disease. Then the same perioperative care that you're gonna do, but diet education, they're now gonna have to go low fat on everything. But we're gonna give you another example. My mother, when she had her gallbladder removed, she loves spicy, loves mustards, loves all the things. I've made the joke before that she is who keeps French's Classic Yellow in business. I don't want that water or paste stuff. I want like the Grey Poupon and the brown, I want the good stuff. Anyway, she keeps French's in business but ever since she had her gallbladder removed, if she has mustard, she profusely sweats because her gallbladder's not there. It doesn't have the bile salts to help with spice and things like that. So certain foods, usually fatty, fried, spicy, are the ones that one, so she knows as soon as she sweats, I shouldn't eat that, shouldn't. So we have learned which foods to avoid for her based on her gallbladder no longer being there. That's your big teaching, is the diet there. There are different types of cholecystitis if you want to look at it. There's cholangitis and all these other, if you see CHOLE though, gallbladder, we're going to keep it there. Some, it will be based on the sac being inflamed, some's on the duct being inflamed, stone. We're just going to use a nice fluffy term, cholecystitis, but there are other types of itises. But if you see CHOLE, and itis, it is going to fall under gallbladder disease, and that's what you're going to do for it. Because I'm not going to pick your brain on all the specifics and which one where. That can be once you get out and specialize. But col and itis, you have a gallbladder disease. We're going to have right upper quadrant pain with Murphy sign. Usually follows a heavy meal, fatty meal. And best education is your low fat diet. So here are your hallmarks for your little flashcard. Got your pain, Murphy sign already, low fat diet, and we're watching for bile duct obstruction. So that's if they choose to do conservative treatment, and we're going to try to give them a medication I'll tell you about in just a second. It may result in a obstruction, waiting on the stone to pass it. So then we worry about the gallbladder bursting. If it does, then we have to do a washout and watch for peritonitis and all the things. Pancreatitis, most often your secondary problem for gallbladder disease. And then infection, peritonitis, most common there. So for this class, we talked about your 4 F's. You can technically add the 5th one. You're fluffy now that we have the obesity pandemic. So we can say all those. There's your hallmarks. Where could this pain radiate because this is going to be where we kind of get to the nitpicky to help me tell between this and another syndrome we'll talk about shortly. So where will gallbladder radiate to? Anybody ever had gallbladder problems? You know where it might be?
Shoulder and left side sometimes.
All right, it's going to be right to the right shoulder. So it's going to stay on the right side, but it's going to radiate up into the shoulder or scapula. Will be on there. Some other things I may tell you about. Y'all remember last semester when we did some alternative medicines, we love to talk about herbals. Yes, Stephanie?
I also had a gallstone, and mine was actually hard to diagnose because my pain symptoms were not where they were supposed to be.
Non-traditional?
Mine were non-traditional. Mine was always right flank pain, and I had like a labor job at the time, so they just told me I had back pain. And so for like 8 months, they just kept telling me to do physical therapy. I'm like, it's not it. So it could also be right flank pain.
You're atypical.
I was atypical.
You're atypical. That is not textbook.
Yeah,
So
because that's where
thank you
mine
for being
was.
my 1%,
Yeah.
or it's probably more than that, but that's not a typical textbook one, so it just, I guess the positioning of where it was, it made it look like a kidney stone or something else, but,
Do they have to supplement with like lipases or anything like that?
they will for pancreatitis. They will not for gallbladder. Now, if they do wind up with pancreatitis, they could give them the digestive enzymes, the pancreatic enzymes. So just a little bit more detail on that right upper quadrant pain for classic presentation is gonna be where it goes to that right shoulder or scapula. Going back to the herbals, people love to try to self-treat with it. There's a, herb out there, supplement called Golden Seal, one word, Golden and Seal, the animal, one word. Can be used to help decrease gallbladder inflammation, but there's not enough science out there to determine whether or not that one's effective, and it's not on my list that I would prescribe. But you will hear patients that want to do alternative medicine that will try to take that first before they have a lap chole or do all the other necessary steps. If they do choose to do so, and they're of childbearing age, they need to stop Golden Seal if they are pregnant, because it is detrimental to the fetus. So do not take Golden Seal if they choose to do that if they're pregnant. I think that's it. So let's look at our classic textbook patient. Sharp pain, upper right belly, especially after eating, fatty meal, heavy meal, something of that nature. Right upper quadrant pain, most associated with heavy meals, as we'll call them. Nausea, vomiting, but positive Murphy sign. It may radiate up to that right shoulder. We're gonna have an elevated white count, especially if it is from the bile stasis, biliary stasis. We're gonna have elevated AST, ALT. What kind of diagnostic is that? What's that looking at? Yep, that's your liver. I heard it very quietly. Who said liver? Who gets credit? Thank you. All right, so liver enzymes will elevate, but that makes sense because of the triangle. Our ultrasound would show gallstones, or it would show biliary sludging. You may see that word on a CT or ultrasound report about sludging. Or you might see thickened bladder wall. That just means that it's so distended that it's trying to, or irritated, inflamed. So we talked about treatment options. It's gonna be that laparotomy, or the lap chole. Sometimes if it's due to the gallbladder or the bile, biliary stasis, they may place what they call a T-tube. And so they will place that inside the gallbladder duct to try to drain off excessive bile. Stephanie?
I'm sorry, back to being like the 1% patient, because I think it's interesting, because it's not always like the heavy fatty foods, because like at the time I was vegetarian, so what I learned in AP2.
Did you lose weight quick?
No,
I didn't know, because sometimes, vegetarian will lose weight.
no, I didn't, I was like pretty average. But, what I learned in AP2 is because you're not using all of like the bile because it's not digesting.
Biliary
fatty-
stasis.
Yeah, it's biliary stasis, so I was trying to put it to like correlate with biliary stasis.
Okay. Your most often is gonna be your stone, but biliary stasis is another culprit.
Yeah.
So we talked about if it is related to the bile and not a stone, they can place a T-tube just to drain the excessive bile and prolong for having to have surgery. Or surgery, removal.
Do they put stents in the bile duct?
I have heard of some. It is not often. I see more tubes placed than stents, but I have heard of biliary stents.
Okay, we just do a lot of biliary stents in small animals.
I don't know if it's because of, anytime we stent, it's just putting it off. And so that's, I guess, why they don't see them. They'll just go ahead and yank them out. But I have seen a good number of T-tubes if it's related to biliary stasis. Some agents that you can give them, again, for conservative treatment or to put off or prolong before we have to have our gallbladder removed. There's two medicines, ursodiol, urso, just like this. Ursodiol, or cholestyramine. We call it Questran. These are bile sequestering agents. For a fancy word. Bile sequestering agent. And those are gonna help, to effectively, so they're like bile salts and, will help with metabolization if your, gallbladder is not able to have enough bile for digestion, or we have stones that are occluding and we're trying to help promote, we can use these agents to try to help them metabolize food so that we don't have, that right upper quadrant pain, nausea, vomiting, all the things, and hopefully can help improve our cholecystitis. And then for this group, again, we would want to focus on fat-soluble vitamins, if need be, because of malabsorption, because if we can't digest the food, because they have what they call Duffin syndrome. If they eat that large meal, they're just gonna go. We didn't absorb a thing, so it might have to boost your fat-soluble vitamins. Yet again, gonna be a very common theme tonight, we have fat-soluble vitamins. So based on that, let's see. So how does that high-fat meal trigger cholecystitis or cholecystitis symptoms in your patient?
Tells the body to release cholecystokinin, is that it?
Ooh, getting fancy. It's fancier than I need, but I like it.
Yeah, and then it tells the gallbladder to contract.
And then that elicits the pain response and the dumping. But, so good stuff. Don't have to get that fancy, but it elicits your gallbladder to squeeze. I do need you to have that. Because fat, we need the bile. If you eat fat, we need bile. And so that squeezes the gallbladder, it's already irritated, elicits the pain and the rest of the symptoms. But psych. Yeah.
This is my whole world.
Let's see.
Dumping syndrome just before.
So what dietary modifications are needed or recommended for gallbladder disease?
Low fat.
And may have to increase
Fiber.
fat-soluble vitamins, so all four of those. Why is NPO status important, if anticipating, that is not worded correctly. Why is NPO status indicated if the patient is doing conservative treatment for gallbladder disease? There we go. Rest, because remember, for all these inflammatories, what's the two things you gotta do if nothing else? Rest and less stress. So if nothing else, so that's the purpose of an NPO. Also, you can argue for intensive surgery if we don't improve. That's it for those as far as the prep. Okay. Y'all feeling okay? Okay. Let's try some pancreatitis, our neighboring friend. So 2 classes here. You got acute. So that one is curable, right? And then once we hit chronic pancreatitis, it's progressive, irreversible, and we have it that way. Most common cause of pancreatitis, what you think?
Drinking.
Alcohol intoxication can cause it. And then we can also revert back to our diet. We can talk about if our gallbladder's absent and now it's all on our pancreas. Those Super Bowl Sunday foods, so fat, fried, and spicy, in the absence of a gallbladder, because then our pancreas has to pick up the slack. So what's essentially happening is that we are going to have a autoimmune response where your pancreas is autophaging itself. What's autophaging?
Eating yourself.
Eating itself. Doesn't that sound fun?
Yes.
Usually starts up in the tail of the pancreas because it's the smaller portion, so it's easier to erode, so that's where most of our pain is. So looking at your picture of where your pancreas is sitting, the tail, where are they likely to have their pain first? It's really going to be epigastric. I don't know why it goes in that left upper, but it's really going to be in that epigastric region is where it'll initiate. and they're gonna say it goes to their back. And that makes sense, because as it continues to eat away the pancreas and goes down to the larger section, it's going to radiate to the back. Their buzzwords would be stabbing, sharp, continuous pain. It does not have a let up period. It is like somebody has a knife in their midsection and it's just there. And just somebody's sitting there turning. And so pretty constant. Nausea, vomiting, because they are throwing up what they can't eat. So again, NPO status for them, and then low grade fever. There's two lab values. They're gonna be out of whack. I call them the two evil sisters, because it is pretty, you have my undivided attention for three types of pain. Pancreatic pain, cancer pain, and I'll come back to my third one when it hits my brain. But pancreatic's one of those that does grab my attention, because it is one that does not let up, and until it resolves, they're in pain. So they're getting the good stuff. Dilaudid or hydromorphone is the recommended drug for this one for pain relief. So that should tell you how severe the pain is if they're getting Dilaudid. Some patients come in and ask for it by name because they like it. These patients actually need it, because we're not going to get into the chemistry, but it's the best drug that's going to help their condition. NPO, so that the rest, all that, IV fluids, because they're NPO. Electrolytes, they have upper GI issues most of the time with this one. So again, you're going to worry about your potassium. But because you're having emesis and not as much this way, I'm more worried about water and pH balance up here. So metabolic alkalosis, we could even watch them for. And then with this one, they're prone for all sorts of weird stuff. Shock and respiratory failure I put because those are the most often or most common. You might even see clotting disorders like pulmonary embolism, DVTs, DIC, disseminated intravascular.
Coagulopathy.
Thank you. So where they just kind of clot everywhere. I have no idea other than it just occurs, but it is something that can happen. So in your Saunders book, you'll see complications of pancreatitis. You're going to see all sorts of weird stuff. We're going to go for the ones that we clinically actually see happen very often, but you never know. With Hesse, they love picking weird things. Think you're going to go left and they'll zag right. So, but we're going to go with what's common. And then nutritional support, if this prolongs or we have chronic pancreatitis from an alcohol abuse patient, for example, they will need TPN or enteral feeding, because if we do large boluses and activate that pancreas, it's going to get inflamed, mad. And as of now, are there any pancreatic transplants, pancreatic cures?
No.
Not, we're working on it, we're close. Because if we can do that, we can get diabetes cured and all that good stuff too. Trying to think, everything, there, okay. So your classics, how we're gonna present, pain location, typically epigastric, severe, nonstop, does not let up. Smack the knife, if you will, and it will radiate to the back in later stages or in chronic stages as the pancreas has gotten to the larger section. We're going to do NPO because anything we eat, the pancreas is activated. Those evil twin sisters, Amy and Lisa, amylase and lipase will be elevated and indicate that we have pancreatitis. Our most common complication would be a pseudocyst, which is just essentially an infectious little nodule that's going to take off. But shock and respiratory distress are the most common too, from the volume loss and the emesis in there. Some patients may say that they have relief by leaning forward or sitting up. I can't say that I've seen that, but it is in the book that they say. Two additional signs. This is your test of signs. Coming up, we're going to keep drawing on our little abdomen. He's going to be all marked up by the end of the night. Yep. So we got, all right, let's go back. Which one's the right lower quadrant? McBurney. Then up top above him, we got Murphy, Virgo. So now we're gonna add some more. We're gonna add colon sign right there with your navel. So colon's gonna go in our navel. It's literally called the black eye around the navel. It just looks like your navel. Somebody punched it, it's got a little black eye around your navel. So colon sign, that is usually early, but it's related to blood loss, from pancreatitis. And then I don't have one, so we're just gonna kinda draw your belly and we're gonna put it over here on your backside. We're gonna put gray Turners, or you can just call it Turners for short. It's going to be, because you have to turn the patient over to see it, it's on their flanks, but it's the same thing. It's gonna be bruising from hemorrhaging related to pancreatitis on their flanks. Gray Turner sign. So bruising, discoloration related to hemorrhage, blood loss from pancreatitis. Because we talked, strange thing, I would never associate the pancreas with bleeding stuff, but you may see them with DVTs, PEs, all these bruising, bleeding things. It's weird. And it's a little advanced to talk about, but I want you to know to look for those. So we're up to 4 signs. So classic patient right here is going to be severe pain in the middle of my upper belly, goes to my back. Severe gastric pain, does not let up, nausea, vomiting, fever, elevated lipase, amylase. CT scan will show pancreatic inflammation, there'll be NPO. So, a couple of things we're gonna treat them with. What do they need because they're NPO? Always.
IV fluids.
Fluids, anytime they're NPO, you're just gonna throw fluids at them, so. Then pain management, what's the good drug they gonna get here? They gonna get the Dilaudid. Yes, hydromorphone. Dilly did. The hydromorphone, and then their NPO. And then after or during, resolution of when they finally start eating again, what are they going to need?
Lots of vitamins.
They're gonna need those digestive enzymes, or they'll call them pancreatic enzymes. So we're gonna try to supplement those enzymes so that we don't stimulate their pancreas to produce them and agitate the pancreatitis over again. So more often than not, you'll see the enzymes prescribed for your chronic pancreatitis patients. Acute just depends on the severity and how they're doing. But chronic, I can promise you they're gonna get the enzymes because we don't wanna do anything to piss off that pancreas, so. Trying to think. Big takeaways. Two hallmark symptoms of acute pancreatitis and why they occur. So give me a hallmark symptom. Oh, well, good, and so what's their complaint gonna be?
Sharp stabbing.
So why, and then why is it that way? Cause what's happening?
It's eating itself.
Autophage, yeah, pancreas is autophaging itself. Then, what's another sign?
The colon and the
You
great.
could do call either one of those, and why is that happening?
Because of the hemorrhaging.
Bleeding disorders or hemorrhaging related to pancreatitis. I like those. We'll come back to some good stuff. Alright. Moving on. Hepatitis. So easy to get hepatitis because there's so many. We're gonna talk about them. But most often it's gonna be we're gonna go with the viral ones. If you had to spend time with hepatitis for your studies, spend time with the viral ones because those are your most commonly occurring. But yes, anytime we stress out our liver, alcohol abuse, drugs, that could be illicit or just polypharmacy on the liver. And then autoimmune diseases that make your liver work into overdrive. Your liver's tired, gets inflamed, and then finally bugs out. But viral hepatitis is where we're gonna spend our time today because that's the most comprehensive one to cover, so that's where we'll focus. Anytime you have hepatitis, it results in liver failure, so it gives you the following look So jaundice, the yellowing or oranging of the tissues, where do you typically see the jaundice first? No, it's gonna be sclera, usually is easiest to pick up on first, cause the white turns yellow. But yes, later signs, now if you're very fair skinned, you might get it in the truncal skin and then elsewhere early. But most, skin tones, you're gonna get it in the sclera first. Fatigue, because if our liver's not filtering, all of those wastes build up. So our liver enzymes are gonna be elevated. And then due to the jaundice, what is jaundice caused by? What's that?
Bilirubin.
Bilirubin. And so when your kidneys break down the bilirubin, what's your pee gonna look like?
Dark.
It's gonna be dark orange or even tea colored, so dark urine. And it's not from renal failure. So a lot of times you'll look at their urine and you'll think, oh, they got some kidney disease. And then nope, you check their liver enzymes, no, they have hepatitis. So dark urine, don't be fooled that it's a kidney instantly. Make sure you also look at that liver because it could be bilirubin. So our liver function test, that AST, ALT, ALK, ALK phos, all of those will tell us how our liver is doing. If it is our viral hepatitis, which we're gonna spend most of our time with. So what are your medicines gonna look like for hepatitis? What are they gonna end in? Veer. So I'm not gonna quiz you on veers, they're just gonna be veers. If you have hepatitis from viruses, just know that they're gonna be getting a veer to treat it. We're gonna provide rest, nutritional support. So when we had our cirrhosis, does anybody remember what type of diet they needed when liver was out in cirrhosis? Increased carbs and the protein, believe it or not. And then if the protein got out of hand and caused some hepatic encephalopathy, you gave them this drug to counteract the byproduct of the protein. Lactulose for that ammonia buildup. So remember, when we break down protein, it produces ammonia. Normally the liver gets rid of it, but if it can't, we'll give lactulose. Education on prevention. So let's talk about vaccinations. So what types of hepatitis can be vaccinated against? B for sure, because you all had to have it to be here. Now there's another one that can, but we typically don't give it here because we're not a third world country, or I say third world, but A, you can vaccinate for Hep A. We don't do A here because most of our everywhere we live has a filtered water system. But in places that do not have filtered water systems or hygienic water systems, we would want to vaccinate for Hep A. So a lot of our mission or military workers will get vaccinated for Hep A just in case they come in, because we'll talk about routes in just a second. Contact with contaminated water or food sources. Then safe practices, your number one safe practice, even as a nurse, was what? What's your best safety practice? Wash your hands, as Amber said.
Wash your hands, wear
Wash
some
your
gloves,
hands.
and don't reach
It
after your
is,
meal.
because think about viruses, if it's contaminated food waste or fecal matter, hand washing's gonna eliminate that risk, or washing fruits and vegetables, things of that nature. So good, safe practices for washing the virus away. One thing that we don't think about, but now we need to because of, so that's why y'all, for my seafood eaters, you'll know this more than my non-seafood eaters. Have you noticed with seafood now, they mark where it came from?
Yes.
So they'll tell you a state or city or country and things like that. The reason they do that is because of the risk for Hep A. So the reason that your seafood is marked is so if your tilapia came from China and if this particular village didn't have or whatever, did not have a filtrated water system, think about your tilapia is swimming in the infested water, we'll pick it up and you'll contaminate with Hep A. So that's, anyway, so watch your seafood or educate your patients about watching where their seafood's from so that they don't wind up with Hep A. Okay. Then monitor for complications, which is gonna look like liver failure and cirrhosis. Because remember cirrhosis, what does your liver look like? It looks like a little pickle, you pickled your liver with that one. And so think about, we talked about the liver does not filter if it's scarred up and cirrhosed. So that will ultimately cause liver death and all of those symptoms. The that you associate with your general liver stuff. So jaundice is our biggest one. But they're actually late into hepatitis by the time we get jaundice. So we'll look at some other symptoms in just a second. Your liver function test, so your liver enzymes, ALT, AST, ALK, ALK-phos, and bilirubin will be elevated. We're gonna look at the different transmission routes on a chart here in just a second, and I'll try to help summarize it the best I can for you. We're gonna emphasize the importance of vaccinations and health practices to try to prevent the viral hepatitis. And then we're gonna watch for long-term complications. So what were some of those things that happened in cirrhosis, right in here that we could watch for, or educate them on, or have signs of?
Respiratory.
Who?
Respiratory.
It's also behind your respiratory tract. What?
Bleeding?
From what? Yeah, bleeding. What kind of?
Varices.
Esophageal varices. Very good. Would be a long-term complication you might see. Liver cancer, because we know that anytime the tissue has to regenerate, one cell can get carried away and cause us some cancer. But your classic patient is gonna be, I'm really tired, I'm really yellow. And so we've got the jaundice, tiredness from toxin buildup. There's your fatigue. Nausea, vomiting, abdominal pain. But where's your abdominal pain gonna be if they have it? It's gonna be up here, but what's missing? I like it. So mashing on it doesn't change how that pain is, doesn't change the quality. So that's your difference between hepatitis and gallbladder disease. If I mash and make the pain worse, Murphy sign's positive, gallbladder. If I mash, it doesn't change the pain in that right upper quadrant, hepatitis. So that's your, where you're gonna keep them separate. And then that dark orange or tea colored, in severe cases, urine. So yes, you can think renal failure or check on the kidneys, that'd be good, but liver can do that too. Drug abuse and alcohol abuse are your most often occurring as far as the United States, over here on the state side. So we'll look at those, and then our healthcare workers are also at risk due to accidental needle sticks and us working with all these blood products that we can get in there if we don't follow proper health practices and use our PPE. Labs that you're gonna see is elevated liver enzymes and bilirubin, and then they will run after they see the enzymes go up, they'll add a hepatitis panel, and it'll tell us A through E which one it is.
We use an isolation room. We use an isolation room. if
They are, I'm glad you're hanging on to it, because we're really about to talk about some fun stuff there. Before we go too far, let me tell you about the 3 phases of hepatitis. You're gonna see 5,000 different names, I don't care which one you learn. You remember in infection, we talked about prodromal stages and you may see it identified as prodromal, you may hear it called acute phase, you may hear it called pre-icteric, and I'll spell icteric for you. Icteric. So all that's meaning is if they're jaundiced. So pre-icteric is like pre-jaundice. Don't care which one you use, prodromal, acute, pre-icteric, you're gonna see several depending on what book you pick up. The most important thing is 3 phases. So the acute phase is when the hepatitis has been acquired, it has started doing damage to the liver, but it has not made it severe enough that you get the physical signs or symptoms yet. You are still contagious in that acute period for hepatitis. So all the people, once you're diagnosed, we kind of need to share with who you've been around, because if you've been sharing needles with your, it's sad to say, but let's say you test positive for Hep B, I'm not really probably gonna catch it until they're in that icteric stage. So anybody that you've been sharing a needle with past, and you're gonna have to look at your incubation period, I'm not gonna expect you to know those, but different hepatitises, when we look at the chart, have different incubation periods. So when you have acquired the virus, it's gotta incubate before it shows the symptoms, but it's still contagious, if it makes sense. So think about flu. You're typically contagious for flu 24 hours before you have the first symptom. So same thing with hepatitis. You're contagious for a incubation period before you actually have the physical signs and symptoms of hepatitis. So we would want to report near contacts. so that they may be also tested for hepatitis and try to get a hold of it. Highly contagious, if it's the viral hepatitis, so we're really pushing for hand washing, and for cooked foods, especially in that seafood family, so that we eliminate the risk of Hep A. Then you have your icteric phase, if they have jaundice. But if they don't have jaundice, but they have the other symptoms, you're just gonna add the word "and" in front of it and lowercase the I. So your jaundice will be your clarifier on your second stage. So icteric or anicteric, but it's the second phase. And that's gonna be where they have the physical symptoms. So the jaundice, the elevated liver enzymes, fatigue, nausea, vomiting, the darkened urine from the bilirubin, all of that. But does it make sense to you that if they're anicteric, the bilirubin's not gonna be as much in the urine as if they were icteric and had the physical jaundice? So that'll be it depends. Then lastly is the recovery phase, so all of the physical symptoms have alleviated, but yet we still need time for our liver to de-inflame or anti-inflame with those medicines, so we need time for our liver to recover and get back to full function, but the active viral load of hepatitis is gone. So I personally am not gonna drill you on the 3 phases, but I do want to make you aware in case Hesse goes down that rabbit hole. You may see all those different interchangeable terms. So if you see like a prodromal, acute, or pre-icteric, that would be your first stage. Either icteric, anicteric, that just active symptoms of hepatitis. Recovery or post-dromal would be the liver is still inflamed, irritated, but it's healing, viral load's gone. We talked about hand washing. Okay. So I'm glad that, Amber, say what you said again about your patient and how you treat your isolation room. Chase that rabbit, because you're my next topic.
I don't wanna be the next topic.
Well, not you in particular, but what you brought up is the next topic for hepatitis.
We put him in isolation.
Yeah,
because
why?
We draw the blood, and it stays on the surface for 7 days, so they go in isolation, just in case anything happens, you have a patient in another vicinity, you have to do the whole isolation thing.
And then they'll sterilize it, and then you do the Trudy for the room, or UV the room, or what? How do y'all get rid of it in the isolation room? Just wondering, I mean,
We
no wrong.
just bleach it,
I got you,
yeah, we bleach everything
and
in
that should
there.
be fine.
Yeah, nobody's allowed in there besides an ISO patient.
So this is ugly to say, but I'm using it more for a memory trick, not that I would want you to ever treat or designate your patients this way. But have you ever, like back in the 80s with the AIDS scare, treat them like an AIDS patient or whatever, just they casted all of the AIDS patients to a corner of the hospital and just let them go. So very much you have to treat your hepatitis patient, I mean, for a lack of better, they don't need to share utensils, they don't need to share bathrooms, they need to be cohorted because it's very contagious and can transmit both through blood or contaminated bodily fluid. So in your book, you're gonna find where they won't share any items. They don't need to prepare food for other people for fear that they get a micro stick, like if they're chopping tomatoes or something and they get a micro stick that maybe they didn't bleed, but it was small enough to transfer some cells onto the, anyway, it's highly contagious, so they need to be cohorted and separated until the viral load or they have reached that recovery or post-dromal phase. So, some drugs you might give them. Remember that in these patients, we obviously need to avoid alcohol or liver metabolizing drugs. So Tylenol would be the big one that would come to my brain for a hepatitis patient, but any other liver drug that you may know. We might give them antihistamines or antiemetics. So you might often hear that hepatitis patients itch because of the toxin buildup and the jaundice, kind of itchy. So that they may get some antihistamines to help with itching, antiemetics for the GI upset, and we talked about the cohorting them. That is about it there. And we got one more to go, then we're gonna ask you some questions about it. Let's see. I'm gonna give you a break just because of the questions, so let's make it a nice round hour. So I'll see you at 6 o'clock for our last one, and then we'll do our quiz down. Make sure